So as you remember from the beginning, we talked about how EGFR is a part of a larger family of these ERBB receptors. And now I'm going to focus on ERBB3, which is called HER3. And what we know about HER3 is that it's actually also frequently seen in non-small cell lung cancer. In fact, it's seen a little bit more frequently, more commonly in EGFR mutant non-small cell lung cancers. And this is the other, I think, exciting drugs that we are seeing. So this is a publication that came out this year from Dr. Yanni and his colleagues, and it looks at the safety and efficacy of a drug called Patritumab Deruxtecan. And again, it's in patients with EGFR non-small cell lung cancer. So what is Patritumab Deruxtecan? So on the left, you see our EGFR receptor, which is actually HER1. And then here on the right, you'll see HER3, which, as I've said, is actually commonly found in non-small cell lung cancers, and especially in EGFR non-small cell lung cancers. So what the drug does is it comes in, it binds to the HER3, and this drug is actually linked to a potent chemotherapy. So what this drug does is it directs the chemo only to the cells that have this HER3. And in this situation, we think that the HER3 is more found on patients with EGFR non-small cell lung cancer. I know this is a really busy table, but all I really want to demonstrate is what is on the bottom. These are the 81 patients that were on this study. And you'll see on the bottom talks about prior cancer regimens. So again, a lot of these patients had prior osimertinib, prior chemotherapy. Some of them even receive immunotherapy. So again, these are patients who receive a lot of different treatments. And you'll see right at the top says number of prior lines. It talks about some patients had even 9 lines of treatment before this. And again, here we want to highlight what the overall response rate was, is about 39%. So again, that meant 39% of patients had a really good shrinkage of their cancer. And again, you'll see that another subset of patients also had stable disease, which means that this, again, this drug seems to be pretty effective in patients who have progressed on their treatment. Of course, we'll see that there are side effects to all of these drugs, and that's when we look at the bottom. This is grade 3 or higher. That means these are more serious side effects. We see a lot of these side effects are related to blood count changes, which are monitored very closely while on this treatment. The most important side effect is what I've highlighted below in red. It talks about ILD, which is interstitial lung disease. Unfortunately, with this class of drugs, we see very rarely that sometimes patients can develop inflammation in their lung, and that can cause them to be short of breath, and that could be long-lasting. We are learning and trying to understand the mechanisms behind it and ways to prevent it, and as I've said, it's fortunately a very low likelihood, but it is something to be aware of. So my takeaway points from all of this, it is, again, if we've covered nothing else, I think for me, it is important to remember that we always should check for the presence of EGFR and other driver mutations in metastatic non-small cell lung cancer. And again, that is considered a standard of care. Medications that target EGFR, the TKIs, have completely changed the longevity and I think the quality of life for our patients with EGFR mutant non-small cell lung cancer. We do need more directed therapies after progression on osimertinib. I think we do have some suggestions that perhaps there may be a benefit to continuing the osimertinib if the EGFR mutation is still there. We would always like to encourage participation on a clinical trial that is feasible and available. And again, outside of a clinical trial, I really don't see that there's too much benefit to immunotherapy, but that is an active area of ongoing investigation.